Okay, thank you so much for having me. I'm sorry about that technical hitch, and thank you for that introduction. So I don't really need to say too much about what I do. I'm a researcher and a psychiatrist with a special interest in neuropsychiatry, working in South London, and I also run a specialist clinic jointly with a neurologist, Esther Coutinho, where we see patients with autoimmune and increasingly also infectious encephalitis. And I want to talk today about really the role of the psychiatrist or the neuropsychiatrist in the patient journey of someone who has encephalitis and also their family and carers. I should probably start by just saying a bit about what neuropsychiatry is. So it's a branch of psychiatry, and for people that don't know, psychiatry is a branch of medicine. It's different to psychology. So we have the same basic medical training as any other branch of medicine, be it neurology, pediatrics, even the surgical specialties. It's just that the specialist training is then different. And neuropsychiatry is that branch of psychiatry where we are largely concerned with people who have neurological or neurosurgical problems that also have mental health needs and difficulties as well. And that can be anything from sort of brain tumors, neurodegenerative diseases, epilepsy, but also brain inflammation or brain infection, so encephalitis. So I'm going to talk today about the role of psychiatry in a number of different stages. I say before, during, and after, but I guess what I mean is at the recognition stage. It's quite important these days that psychiatrists know how to recognize encephalitis, because we potentially see quite a lot of it that maybe we didn't spot before. Management, when someone's in hospital with encephalitis, you know, how can we help? What can we do? And the area that I'm sort of really passionate about is the follow-up, the long-term follow-up of people after they leave the hospital, when they go home. For often for people, that's where their journey really begins. And I think there's a lot of unmet need, emotional problems that people face that maybe they don't get the help that they need. And if there's sort of one message I want to say today, is that we are there to provide support, you know, at every stage of the journey. But there's a difference between my experience and yours. I'm a clinician. I've seen many patients with encephalitis at various stages. I'm lucky enough not to have direct experience of it myself or in my sort of family or loved ones, which will be very different to the experience with you. And so I just want to sort of, well, sort of thank you for your interest. And I hope that, you know, I can learn from your experiences today and over the years. But also I want to highlight a little bit about how the different ways of thinking about illness kind of when you're a doctor differs from when you're a patient, and how so much of the important patient story can be lost. So this is a very quick case history that I'm going to talk about a patient with encephalitis, and you'll see that there's a lot of technical jargon, and that's purposeful in a way, and I'll try and explain it. And I want to sort of get across how much detail can be lost when you say this, when you tell this kind of medical story. So 19F, this is a 19-year-old woman, female. She has a 3-week history of insomnia, multimodal hallucinations. That means hallucinations. She smells, sees, hears things that aren't actually there. Misidentification delusions. She thinks that her family have been replaced by imposters. Emotional lability. 1 minute she's terrified, the next she's very happy, the next she seems extremely down. She's admitted to psychiatric hospital, and because of her level of agitation, she's admitted to a psychiatric intensive care unit. This is the highest level of care that we provide for patients who are potentially a danger to themselves or to others. 3 weeks later, she develops catatonic symptoms. That's a kind of syndrome where people become very rigid and unresponsive. And dysautonomia, that means her blood pressure, her heart rate are all over the place. And mutism, she stops speaking. She gets given injectable antipsychotics and sedative treatments. And these are nasty, sedating treatments, and sometimes that can be quite a lot to take, but these are ineffective for her. She doesn't get better with them. She's transferred to a general hospital where an EEG, that's, as I'm sure people know, something that measures your brain waves, the electrical activity of the brain, shows this very complicated description, which is basically suggestive of encephalopathy of some sort. A brain scan is normal, but then what seals the deal is this blood test and a test in her spinal fluid, which shows the presence of NMDA receptor antibodies, which leads to a diagnosis of NMDA receptor encephalitis. And then she's given immunotherapy, plasma exchange, high-dose steroids, rituximab, which is a medication which stops the production of antibodies from the B cells, and she's treated with antipsychotic treatments. So that's the medical story, but it misses so much. And I want to sort of show you why it misses so much. So we said she was transferred to a general hospital. Well, yes, she was, except about 4 hours after she was seen in the general hospital, she was sent back to the psychiatric hospital because they said they didn't think this was an organic medical problem. They thought it was a psychiatric problem. And actually, that happened about 3 times. She went back and forth between the general hospital and the psychiatric hospital until eventually they conceded that this probably was an organic problem. The EEG is clearly abnormal, but what this doesn't show you is that was her 3rd EEG. The first 2 EEGs were in fact normal, and it's very difficult to get an EEG on somebody who is as agitated and distressed as this woman was. I should add, this woman is a sort of composite of a couple of cases that I've seen. These antibody tests were positive, but the reality is, especially at the time, you know, even now to an extent, it sometimes takes a number of weeks for these antibody tests to come back. And during that time, especially in London, in the UK, there's a shortage of psychiatric beds, and often these patients are moved between different hospitals, which is, of course, is very distressing for them and their patients and their families. And I say that her symptoms fully resolved. Well, actually, I'm talking about the neurological symptoms there, because the reality is that she was left with anxiety and depression, which, although she's being treated for it and has got much better, you know, has been really quite significant, and she's needed a lot of input for it. Not only that, but she was discharged on steroids, she was discharged on an antipsychotic, both of which sort of conspired together to cause her to gain a lot of weight, in fact, to develop type 2 diabetes. And it took some time until she came off those medications and then was able to recover her physical health. So things are a lot more complicated than the case studies often portray them to be. And I want you to sort of think about that as we go. But patients often ask, they say, you know, why am I seeing a psychiatrist? I've got a problem with my brain, not my mind. And the answer that I give is something that someone told me when I was training, is that the mind and the brain both live in the same box. They both live in the skull. And, you know, anything like encephalitis, which causes huge inflammation in the brain, is bound for this very reason to give you sort of symptoms of mental illness to some extent. And just because mental illness symptoms can't be seen on a brain scan, that doesn't make them any less real. Lots of symptoms can't be seen on a brain scan. Headache can't be seen on a brain scan. But I think sometimes we are slow to give these psychiatric symptoms the same kind of status or respect that some other kinds of symptoms do get given. And there's this idea that neurologists are brain doctors, but psychiatrists are mind doctors. And I just don't think that's true. I think we need to sort of get rid of that kind of caricature, because in fact, I think we are both people who deal ultimately with the person first and foremost. But also, 1/4 of us will experience mental illness in our lifetime at some point. And therefore, we do have some experience of these kind of symptoms. And encephalitis doesn't discriminate. It's equally likely to affect somebody who's already had mental illness or is likely to develop mental illness as it is to affect someone else. And we talk a lot about encephalitis being a hidden disability. And I would add that when it comes to the psychiatric symptoms, maybe that's even more true, because there's a lot of stigma when it comes to psychiatric symptoms. And that's something that I think can be a real barrier in people getting the kind of care that they need. And, you know, actually coming to ask for that kind of help is often the difference between somebody living with intolerable anxiety or fear or terrifying experiences, potentially for the rest of their life, or actually getting the kind of help they need and being free of those symptoms. So what are the kind of mental health symptoms that we see in encephalitis? Well, broadly speaking, they're problems with emotions, behavior, thinking. And to be a bit more specific, there are cognitive problems. These are probably the most common. They are universal, particularly in the acute stages of encephalitis when people can become acutely confused. But even in the longer term, problems with memory, problems with language, problems with planning that can make sort of complex tasks very difficult. That's what we call problems with executive dysfunction. Mood problems, people can become very severely depressed, but they can also have the opposite. They can become what we call manic or hypomanic, and that's where their mood is so high that they can't rest, they can't sleep. They can become very agitated, very difficult to treat, and can be quite distressing. Also, they can become apathetic. That's when a patient lacks the motivation to really do anything. And sometimes we see that after encephalitis, and you can see how that might be very distressing, more so to actually the carers and the families. Anxiety, well, I mean, everyone has experience of some anxiety or other. I'm anxious giving a talk like this, but the kind of anxiety that you can see in encephalitis can be very, very severe and can either be generalized, it can be sort of focused on specific issues. Sometimes it can manifest as obsessions and compulsions as well. The sort of group of symptoms that psychiatrists spend a lot of time thinking about are the psychotic symptoms. And broadly speaking, what psychosis means is it's a loss of contact with reality. So people can see or hear things that aren't really there. People can believe things, sometimes very strongly, that aren't true, despite all the evidence to the contrary. That's what we call a delusion. And you can understand how if somebody has that belief and they don't believe there's something wrong with them necessarily, it can make treating them very, very difficult indeed. And sometimes their thinking can be so confused that it's actually quite difficult to understand what they're trying to say at times. So it can make communication very difficult. I should add that these are symptoms, not diagnoses. So just because somebody with encephalitis is experiencing a psychotic symptom, that doesn't mean that they have a primary psychotic disorder like schizophrenia or schizoaffective disorder. In the same way that it's possible to have a headache without having a migraine, for example, or you can have a single seizure without having epilepsy. But you know, stigma is a problem whether or not we're talking about diagnoses or symptoms, right? Because it is stigmatizing to have a diagnosis like schizophrenia, but it's also stigmatizing to have an unusual psychotic experience at all. And particularly, you know, there are some cultures where these things are more stigmatizing still. And I think what this does is it all conspires to make these symptoms that people don't talk about as readily as they should, even to their doctors. So let's just talk about the individual kinds of encephalitis. I'll focus a bit more on autoimmune because that's the area that I have most sort of clinical and research interest in. But in viral encephalitis, you see all sorts of psychiatric symptoms, but they're often more accompanied with neurological presentations as well. So the kind of the seizures, the focal neurology as well. And chiefly one gets, in terms of the psychiatric symptoms, agitation and confusion, sometimes part of what we call encephalopathy or delirium. So people can become psychotic, they can have hallucinations, which can be quite distressing, but normally it's part of this very confusional state. Occasionally you can get these isolated psychotic presentations. I very clearly remember one patient with what was called a postpartum psychosis who had recently given birth, who became psychotic without confusion. She still knew what day of the week it was, for example. And she in fact did end up being diagnosed with a viral encephalitis. But these are rare. Cases of mania like this are rare. Cases of catatonia are also rare. But it's unsurprising. These viruses, they have what we call a tropism, typically. Typically herpes simplex virus, the cold sore virus, which causes so many cases of viral encephalitis. They preferentially affect the temporal lobes, the medial temporal lobes, the limbic system. These are the parts of the brain which control your emotions, your memory. So it's unsurprising that if you have an infection affecting that part of your brain, it's going to result in these kind of symptoms. But autoimmune encephalitis is where sort of the psychiatrist has a really important role, I would say, particularly in spotting it. It's been described that many different kinds of autoimmune encephalitis. I will focus on NMDA receptor encephalitis. And this is from a series from the group of Josep Dalmau from 2013. And you can see these various different pie charts. The one on the right describes patients who are over 18 years old. And you can see all the bits of this pie chart that are in blue, they refer to what you can see along the side says behavior, cognition, and memory. And these are the first symptoms that a patient with NMDA receptor encephalitis presents with. Now, neurologists are not the best at describing psychiatric symptoms in much detail, so they've just said behavior, and that probably encompasses the whole of psychiatry. Fair enough, we're probably not the best at describing neurological symptoms in detail. We probably just say headache, whereas neurologists have 100 words for headache, much like Eskimos have 100 words for snow, perhaps. But this just really shows that at least 3/4 of patients are presenting with, broadly speaking, kind of psychiatric or behavioral symptoms or cognitive symptoms. And interestingly, a minority of patients with NMDA receptor encephalitis will just have these psychiatric episodes or just these psychotic episodes, either at presentation or relapse. They won't go on to develop any of the neurological symptoms, which poses a question of how do you spot these patients? Now, eventually a colleague of mine, Adam Al-Dawani, who's one of the most talented psychiatrists I know, and an amazing researcher, he wanted to go beyond just the word behavior and try and look at the psychiatric symptoms of this disorder in much more detail. So he looked at every single case study that had been published NMDA receptor encephalitis and wrote down the frequency with which these symptoms appeared. And you can see that there's just an enormous range of psychiatric symptoms here occurring in different sort of frequencies. So agitation is the most common, but also hallucinations. But also there are things like eating problems, obsessive compulsive problems, eating too much, eating too little, suicide, bad dreams. Really, sort of any psychiatric symptom you want can in some cases occur. What's interesting is that this study suggests that this disorder doesn't look exactly like the psychiatric disorders that we're used to seeing. It's not exactly the same as schizophrenia. It's not exactly the same as schizoaffective disorder, but that doesn't necessarily mean that it's easy to spot. And that's certainly the case that really many clinicians still have trouble spotting this disorder. So everyone, I'm sure, knows this book, Brain on Fire, Susanna Cahalan. It's her story of NMDA receptor encephalitis, which presented initially with psychosis, which was misdiagnosed as schizoaffective disorder. And it's only when she eventually collapses and she has a seizure that she's admitted to a neurological hospital where she gets the diagnosis. And already you can see this is kind of setting up a distinction between the psychiatrist who gets it wrong and the neurologist who gets it right eventually. And sadly, that's a bit of a caricature, but maybe there is some truth in it. And she asks this question. She says, how many people are currently in psychiatric homes, wards and nursing homes, being denied the relatively simple cure of steroids, plasma exchange, or more intense immunotherapy? And I think what she's asking is, are we missing cases? Are we missing cases who might actually have an autoimmune encephalitis, which could need an entirely different treatment response? Now, I think this is a really valid concern, and what better way to gauge the concern of the public than to look at the Daily Mail, Britain's favorite newspaper, which sort of describes a lot of things that are on the nation's mind. And they've 19 separate headlines about autoimmune encephalitis. And, you know, I want you to look at these and see if you can spot any themes, particularly around the theme of misdiagnosis, right? So bride-to-be loses her memory after she develops a rare brain condition that left her unable to recognize her own family and friends. Woman forgot her own wedding day. She thought the year was 1860 after a rare condition caused her brain to swell and wiped her memory. These are all about autoimmune encephalitis. A mother reveals how her perfect daughter, 14, turned into a foul-mouthed stranger after a rare condition caused her to call friends fat, hit her brothers, and even tell teachers to fuck off. A boy was left in a vegetative state after being struck down by a rare disease that his mother mistook for a common cold. I told my boyfriend I'm a monkey and I'm going to the zoo. A woman was nearly sectioned over her hallucinations, but in fact it's a rare condition that causes her immune system to attack her brain. A teenager whose seizures were put down to school stress had her memory wiped overnight by a brain swelling condition. A man wakes up to discover he's become a father. A new mother forgot that she'd given birth and couldn't even remember her pregnancy after an immune attack on her brain. A woman was misdiagnosed with schizophrenia after a rare immune disease stopped her from sleeping for 10 days and triggered hallucinations that she was being chased by Mexican drug lords. Her brain is on fire. There's a condition which makes young women discover that makes them hysterical and then catatonic. Was I mentally ill? A sad story about toddlers sort of being scared of monsters. A woman who blamed tiredness and headaches on a breakup actually had a rare illness which caused her brain to swell and left her in a coma. Sufferers of schizophrenia may actually have a treatable immune disorder that could be cured. I'll just fast forward through these. They said I was putting it on. A teen who suffered terrifying seizures that made her hallucinate was told that's not how seizures work by psychologists before being diagnosed with a rare brain disease. And my husband thought I was possessed by an evil spirit and doused me in holy water until it's discovered that delusional symptoms were caused by her body attacking her brain. So the theme that's emerging here is this worry that patients might be misdiagnosed, that they might end up being told that they have a primary psychiatric disorder, taken to a psychiatric hospital, possibly not allowed to leave, being sectioned, as we call it in the UK, or incarcerated in a psychiatric hospital. And that's a real worry because, you know, of course, there are cases where this has happened. And I'm sure, in fact, some people listening to this have certainly had a similar experience. So I want to just talk about that for a minute. This is most common in NMDA receptor encephalitis and in autoimmune encephalitis, certainly more so than infectious. In the early days of NMDA receptor encephalitis, about 3/4 of patients were first seen by mental health services. But that doesn't mean that they were all 3/4 were given a mental health diagnosis, it just means that psychiatrists saw these people and offered their opinion. And often at that point, they would say, no, I think this is organic. But sometimes they didn't. And in those cases, which is definitely less than 3/4, they would be maybe given a diagnosis like first episode psychosis or even schizophrenia or bipolar disorder. Occasionally, diagnoses like functional neurological disorder or pseudo seizures are given because some of these patients have these unusual looking seizures that often don't have the normal EEG signs that go with them. This is happening less and less, but really it's a question of raising awareness amongst psychiatrists to be able to spot this disorder. And I think we all have a job to do to try and increase that awareness. But just because psychiatry is involved in your care, that doesn't mean that you've been misdiagnosed. And I should add that, you know, there is a need sometimes to admit people to psychiatric hospitals, even if we know that there is an encephalitis at work, because simply that might be the safest place for them. So just as I said, being on a psychiatric ward doesn't necessarily mean that someone has been misdiagnosed. There is a problem that's emerging recently, and this, I won't say much about it, but certainly we've seen cases where people are being diagnosed with encephalitis on the basis of not very much evidence, and these people probably do have primary psychiatric problems. So this is the kind of the opposite problem to misdiagnosis, and that's something I think that increasingly we all need to be a little bit aware of. So why does encephalitis sometimes look like mental illness? Well, it's caused by inflammation, and we know now that lots of mental illness possibly has inflammation as part of the reason that patient gets symptoms. Encephalitis causes neuronal damage, and we know from other kinds of brain damage, neuronal damage, like brain injury, traumatic brain injury, that you just need to sort of knock out a little bit of the brain, and of course you will cause psychiatric symptoms of one sort or another. Interesting to me is this idea of brain receptors, because as a biological psychiatrist, I spend a lot of time thinking about the different brain receptors that underlie psychiatric symptoms. And of course, these are often the same brain receptors which are targeted by the antibodies in autoimmune encephalitis. So things like the NMDA receptor, the AMPA receptor, dopamine receptor, the GABA receptor, etc. And just as an example of this, in NMDA receptor encephalitis, the antibodies target the receptor which is on the synapse. And it then causes the receptor to move away from the synapse, to cause a sort of decrease in function, what we call a hypofunction of the NMDA receptor. And what's funny is that there's a whole theory about why schizophrenia happens, which is also based around the idea of NMDA receptor hypofunction, this decrease in function of the NMDA receptor. Not only that, but when people are given ketamine, the drug of abuse, that also causes NMDA receptor hypofunction, which also results in similar symptoms, these kind of cognitive symptoms, these sometimes psychotic symptoms, and these kind of catatonic or movement symptoms. So these three different conditions all seem to share something in common, which is dysfunction of the NMDA receptor. And it might explain why some of the symptoms are similar around these three conditions. But what about in the acute phase, when a patient is in hospital? What can we as psychiatrists do? And this is really a role for what we call the liaison psychiatrist, or in America, I think they call it the consultation liaison psychiatrist. So these are the psychiatrists based in general hospitals, the medical hospitals. And we can support medical teams. I think we have an important role in supporting the families and their carers and explaining what's happening. Often we have a bit more time than the neurologists or the medics might have. But really, it's about treating the distressing symptoms. And of course, these symptoms can be very distressing indeed. Sometimes we will have to give patients sedative medication for agitation. And sometimes, funnily enough, for catatonia, we've found that sedative medication can actually make people better, but it often requires very high dose medication. Antipsychotic medication is an interesting one because sometimes our patients do have these very distressing psychotic symptoms which potentially put themselves in danger. We're a little bit cautious with antipsychotic medications because sometimes they can cause sort of rare side effects in this disorder. So we try to avoid that using them unless necessary, but sometimes it is necessary to use them. Immunotherapies, the kind of immunological therapies that patients with encephalitis will often be given, can have psychiatric side effects themselves, steroids, for example, and others. So it's important for us to be aware of this and sometimes treat those effects. Patients often ask, how long should I stay on psychiatric medication? And the answer really is, well, it depends, of course, but the aim is to take people off psychiatric medication as soon as possible. there is no reason that somebody who has become psychotic during the acute phase of encephalitis should then remain on antipsychotic medications for years. So what we normally try and do is that after the acute phase is over, we try and wean those medications off to see if somebody remains well psychiatrically. And the majority of times, actually, they do. So we're normally able to stop most psychiatric medication. But after encephalitis, this is an area that has really been under-researched. Of course, Eva Easton, who's the CEO of Encephalitis Society, has written this wonderful book about, you know, what is life like after encephalitis? Well, you go back to a different life. When you leave that hospital, you come back to a world that is potentially different, right? You have a different relationship with your own body, indeed with your own brain. Sometimes your family relationships can be disrupted. Sometimes your occupation, your job will often never be the same again. And this is going to be hugely disruptive to you as a person. And we now have some data to show that the incidence of new psychiatric disorders following encephalitis is increased. So you can see here that in the year following encephalitis, people are twice as likely to develop an anxiety disorder, nearly 3 times as likely to become depressed, nearly 12 times as likely to develop a psychotic disorder. Interestingly, if you just look a little bit up on that table, you can see that someone with encephalitis is 140 times more likely to be diagnosed with epilepsy. So again, you know, this is a brain condition that then leaves you at risk of developing other conditions, both neurological and psychiatric, and people have to be aware of that. But the long-term psychiatric outcomes, there's not been all that much high-quality research done. We've just finished, and we're in the process of submitting what we call a meta-analysis and a systematic review of every study that has ever been done looking at the psychiatric consequences of encephalitis. And I can't sort of show all the results now, but we need to say, I should say that a lot of the work has not been of a great quality, and they tend to examine one kind of symptom at a time, when what we really need is a study that looks at all the different psychiatric symptoms in one go on really large numbers of patients, and we don't have that. But things like anxiety, depression, and impulse control disorders are probably the most common psychiatric outcomes that we see after encephalitis. Anxiety can include a generalized kind of anxiety, obsessive compulsive symptoms, agoraphobia, that's when someone is too scared to leave the house, or panic disorder. Mood disorders, as we heard, can be depression, it can be mania, but it can also be this emotional lability, sometimes this uncontrollable laughter and crying, which is inappropriate for the context. Some people have been in ITU and have had a terrible time in hospital and might suffer from what we call post-ITU syndrome, where they're plagued by these intrusive flashbacks of what has happened. It's a kind of PTSD, we think. Psychotic disorders do happen, but again, probably less so in the follow-up stage than in the acute stage. Suicide, unfortunately, patients with encephalitis do suffer from suicidal thoughts and feelings, and I think we're increasingly aware of that. And sadly, in some cases, it can lead to people trying to harm themselves. Personality change. Often patients will have problems with anger management, but other kinds of personality change as well. And it really does depend on the individual. And then impulse control disorders. These are really probably quite common. This is when somebody sort of is unable to inhibit their behaviors. So they might engage in uncontrollable shopping or substance abuse or sexual behaviors or behaviors which may be quite out of context for them, out of character for them. And there are many causes for this. As I've said, you know, there's the damage caused by the encephalitis itself, but also it probably depends what kind of a person the person was before encephalitis. Either they already had mental health issues, or maybe they had a family history of that. There's the psychological impact of the illness experience itself and all the trauma that might entail. And really the thing I want to hammer home is and to me is maybe one of the most important aspects, is the quality of the psychosocial support. So somebody who has encephalitis and is suffering by themselves, you know, in a tower block with very little support from friends or family, is going to have a very different experience from somebody who has the financial means to get the kind of help, you know, psychological help, and who has friends and family around them. And I think, you know, these societies like the Encephalitis Society and the other encephalitis organizations who've helped bring today together they have such a vital role in not just supporting the people who are able to get on their laptop and make contact with the society, but also to be proactive and see if we can seek out these people who aren't necessarily able to ask for help, because often they're the people who need our help the most. So how can we help long term? Well, we can support people with medication for their distressing symptoms. Obviously, if there's a crisis, psychiatry will always be there, and indeed we can arrange hospital admissions if that's necessary. One of the things we can do is supply talking therapies, and for example, cognitive behavioral therapy is a kind of talking therapy which has a huge evidence base for working with depression, with anxiety, and a number of different symptoms. And often somebody who has CBT successfully won't even need psychiatric medication. We liaise closely with cognitive services, with neuropsychology, because of course, if somebody has memory problems, that's going to affect the way that they can recover from their emotional problems as well. So we really need to think about what is their level of cognitive function. And rehabilitation, most people will know that you can have acute rehabilitation, inpatient rehabilitation, but also outpatient rehabilitation. And it's important that we liaise with our occupational therapy, physiotherapy, psychology colleagues to try and approach these patients in as kind of holistic a manner as possible. I'll just end on saying I think it's really important that we have multidisciplinary services. There's now evidence showing that if a psychiatrist is involved in the follow-up of these patients, this is with autoimmune encephalitis, they're probably more likely to be able to get back to school or get back to work. But I also think that assessing patients jointly from the start is important. And so certainly in our clinic in King's in London, but also I know in Oxford, every patient is seen simultaneously by a neurologist and psychiatrist. And I think that's a really great model. Where available, specialist neuropsychiatry input is important. But one of the things I feel passionate about is patients should have neuropsychology. They should, where possible, have their cognition assessed, because it's so important in understanding how they're going to recover. But nurse specialists, this is a thing that I talk about a lot, but Parkinson's disease, epilepsy, multiple sclerosis, there in many hospitals around the UK, there are nurse specialists who are able to coordinate people's care, to check in with patients when they're in the community and see how they are. We don't really have that with encephalitis. And I think there is such an argument for saying that we need these nurse specialists, particularly to coordinate with mental health services, because mental health services who are set up for not necessarily for these organic conditions, they may be a little bit nervous about dealing with patients who have these brain conditions. And it's really helpful just to have somebody to say, look, don't worry, you know, this is what you need to know. We'll sort of hold your hand, as it were. So it's important that all the specialties talk to each other. And finally, research infrastructure. I'm a researcher. You're going to hear from lots of researchers today. But it's so important that we have the support, the financial support, but also the infrastructure, so that we know what are the needs of people with with encephalitis, what are their mental health needs, but also how can we target treatments to actually make sure they get better, and to have the evidence to know exactly what treatments are going to work. So thank you. I've gone on by about 2 minutes, I'm afraid, but if anyone has any questions, I'm really happy to take them.
Thank you, Dr. Pollak, for sharing your work with us today. I mean, it's so clear that science is vital in diagnosing patients quickly and correctly. And we thank you for your clear, concise and informative presentation, and your commitment to seeing the person behind the condition. And I note your comments around nurse specialists and the importance of increasing the support that us non-profits can add to people affected by encephalitis. And I'm really thrilled to just be able to let you know that the application that you helped us with was successful, and we will be recruiting a health and well-being, a mental health and well-being role in our support team very soon. So that's some positive news, and thank you for supporting that application. So watch this space because it's a start. So we've had some brilliant questions, some of which you answered as you moved through your presentation, but one I think is still outstanding. Where does the neuropsychology stop and the neuropsychiatry start when dealing with emotional and behavioural after effects of encephalitis?
That's a really great question, and I think that there's an ideal answer, and it's that they should both start at the same time and both stop at the same time, really, because they are doing slightly different things, and they should inform one another. You know, I sort of drew this example before, but somebody who has difficulty in memorizing things because of their cognitive impairment, or difficulties in planning things because of executive dysfunction, they might have a very different psychological approach to deal with their anxiety than someone who doesn't have these difficulties. And so to that extent, the neuropsychiatrist needs to talk to the neuropsychologist to bear all this in mind. But also these treatments and these ways of thinking about a patient are not either or. So I think a patient who is getting neuropsychology input, which is totally invaluable, they might also need psychiatry help and medication to sort of, you know, help those emotional symptoms, regardless of what their neuropsychological impairment is. So I think the answer is those inputs should be working in parallel.